Our next speaker is Dr. Joyce Aycock, who is an associate professor in the plastic surgery division. She received her undergraduate training at Yale, then went to Columbia for medical school, and then University of Chicago for her plastics residency. She came here to the University of Colorado about 11 years ago and has done something that is quite hard to do and I think remarkable, and that's to de novo start a plastic surgery fellowship/residency program. And those of you interested in taking on something like this should definitely talk to Joyce. It is a ton of work. Takes perseverance and pushing many things forward. She's been highly successful at doing this, and with Dave Mathis and the rest of the team, they are really building a world-class training program that a lot of the young trainees really want to go to. In addition to that, Joyce is an expert clinician and runs an extremely busy plastic surgical practice. So we look forward to your talk on education, and thank you very much for doing this.
Thanks, Dr. Schulich. So I know you guys would prefer not to hear about facelifts for half an hour, so I'm going to focus on something that we all share. Everyone here is part of surgical education, and I think as with all things in surgery, the question is always, well, what can we do better than what we're doing now? So we all know that our residency training model is based on an original apprenticeship or indentured servitude model that was started by Halstead. And really, not a lot has changed in how we do it. There's, some differences, and obviously surgery has changed, but the essential kind of see one, do one, teach one thing is still there in the underlying background. And this is actually an effective way to do education because this is a pyramid looking at how much is retained with each kind of learning modality. And so at a lecture, you'll only remember 5% of the stuff that we tell you. So, that's it. But if you actually get to the point where you're teaching someone how to do it, you'll remember 90%. So it's not a bad model. However, due to kind of different changes over the years, there's become more standardization. You now have to do a certain amount to prove that you're allowed to do this. We now have these extensive tables with exactly what every level is allowed to do with and without other people. And this has even changed, since I was a resident not that long ago. The work hours obviously have brought changes. So there are a little bit more limitations on that original see one, do one, teach one. And, kind of over the years, as the amount of training, the number of procedures that we need to do have changed and increased, there's always this question of how much training is required and are people ready when they're finished? And I know by now everyone's heard of this 10,000 hours rule, and it's kind of been condensed down to, just that sentence. And it's based on a psychologist look at experts in all kinds of different fields, that this is sort of the barrier for expertise, 10,000 hours of training. And if you break that down into our 80 hours per week model, that's only 2.5 years. So obviously, that's not enough. And when program directors look at how much people have done when they finish, it is definitely well short of this. This is from 2011, but in general surgery, they broke down all of these different operations into these categories of things that are essential to know how to do and are common. So that would be something like a lap chole, things that are essential but uncommon, and then complex surgeries. And even looking at this top essential common category, there's only 9 surgeries or 9 operations that most of the residents had done 20 times or more. So it is a kind of an important question to look at. And here, these are again, the numbers of the graduating residents from this year. And, even the most common surgery, lap chole, the median was 107 times. And, if you say, well, each one is an hour and a half, if you are going to do 10,000 hours of that, that's going to be 311 years. So that's obviously too much. So the answer is somewhere in the middle. And when you actually read about how to acquire expertise, Anderson breaks it down into these 3 categories, which we skip over in that 10,000 hour rule. So it's really 10,000 hours of deliberate practice. And then it also involves these 2 other steps of feedback and reflection. So deliberate practice doesn't mean just doing it. So it's not just showing up and standing there while you're doing the operation. It's actually based on thinking about what you're doing, and involves 2 components. So improving the skills that you already have, and also extending the range and reach of your skills. And this requires both preparation and concentration. And so those are the 2 things that you need to put in order to really have it count as this deliberate practice. So preparing ahead of time, and then while you're doing the task, concentrating on it. And so, how should you prepare for cases? And I think, this is where maybe different people have different ideas of what to do. So for me, and probably most of the attendings, we say, well, you should read the book. And, when we were residents, most of the time there actually was like a book. Like there was the one, sort of acknowledged book of how to do it. And that's, not necessarily the case anymore. So now it's a question of which book or which article or which website do you look at. And I think that's where we as attendings should be helping sort of guide people, because there is so much more information available now. It can be difficult for the residents to figure out which is the best thing to read, or where should they go for their information to prepare prior to coming to the case. And I think also now a lot of the information is available in video form or podcast form, which I honestly have never done, but I think a lot of the residents and students do prefer this. They feel more comfortable with it. And if there are good sources, it can be, even as good as or better than reading the book. And this is a study where people looked at the actual reading habits of surgery residents. This is from 2015. And when you look at this, it seems that the average resident in surgery is reading about 30 minutes once a week, which is, to me, not that much, but there was only one guy who said none. So at least everybody is reading something except for that one guy. And then looking at the sources, a lot of the reading is just sort of based at studying for the test. A significant portion read only rarely or only when absolutely necessary. So, maybe not as much reading as we think is going on. And then even assuming that we have the best residents, they are reading a lot. I know I showed this before, but it just goes to show that reading can be interpreted in different ways. So this is a picture of one of the program directors at Northwestern in plastic surgery assigned all of his first, when the residents were first going to do a carpal tunnel case with him, he said, read this book, and then you will come to the case and mark the incision. And so the residents all knew he was going to ask them. He told them what to read, but as you can see, I'm sure they're pretty smart. They're, surgery residents at Northwestern. They all completely did a different thing. I mean, one of them even picked the wrong side of the hand. So I think, we tend to jump to the conclusion that, the residents just aren't doing it or whatever, but they may be preparing, but somehow there's something gotten mixed up in the way. So we need to understand that and then work with them to kind of overcome some of these issues. So another issue that comes up too is how do they decide what is actually good information to read? And again, this is where we need to guide people. This is just a study of Stanford undergraduates looking at whether they could tell if something that they read on the internet was valid or not. And they were looking at at these two websites, the American Academy of Pediatrics, which is sort of the official pediatric website, versus this splinter group, American College of Pediatricians, that has all these, kind of out there ideas. And, about half of them couldn't tell which was the more valid source. So I think, again, it's our job to be more proactive in kind of directing the residents or the students in what to look at. So just some strategies for both. I'm divided into residents, things that residents can do, and things that attendings can do in order to try and make your practice more deliberate or get more out of each thing that you do. So for the residents, when you show the attendings that you've prepared for cases, however it is that you can show them that, then you will get more autonomy. It's been shown that that's one of the most important factors in us letting you do something. So definitely, maybe you even just tell them, like, I read this or I watched this video, because if you don't say anything and you interpret it wrong, they may just take away that you didn't do anything. So tell them what you're doing. Also, this envisioning the steps of the procedure prior to doing it. And this is something that people in sports do. It's just a way of preparing. So in your mind, go through things before you do it. And then, sometimes we can't let you do the whole case for whatever reason. Maybe you have to go to a meeting or whatever it is. There's some reason. But even if you're not the one who's doing the sewing or the dissecting, stay engaged, stay concentrated, because you're still going to learn things by just focusing on what they're doing, and you can even just envision that you're doing it. And then finally, I encourage all my residents to keep a record for each case that you do, because again, maybe you only do it 10 times now, and you won't have to do it for another year, but writing things down has been shown to improve memory, and it just helps. I still have notes that I go back to for cases that I don't do very often, and you'll be surprised that something, it feels like you know how to do it now, but you'll forget it if you don't do it for a little bit. And then I think equally important is for the faculty members. A lot of us put the learning on the residents, and it's true, obviously it's their education, they have to put a lot into it, but it's also our job to help them. And we really have to have this teaching philosophy. So you have to have this mindset that the resident is your partner and that you're helping them. Because if you're just there as this great person who is an expert and they're just supposed to watch you and figure it out by themselves, it's not really fair to the residents. So go into each case as the resident's partner and teaching them something. And then again, ahead of time, if you can, recommend, what you would have them read, or an article that maybe they wouldn't have picked up. And also just keep in mind that, there may be these good non-textbook options. I know our society has like a video library, so I will often go on there and look for a video of the way that I'm going to do it and say, watch this video. And then even if you don't do that, right before the case, try to just talk to the resident and set some goals for that case, because depending on their level, each resident's going to have different goals for doing each case. So those are, just some tips about how to make more deliberate practice. The second stage of this process is feedback, and we talk about this a lot. And this is, again, a table of the different generations. So now most of the attendings are probably baby boomers or Generation X. I'm Generation X, and then the residents are Generation Y or millennials. And these are obviously generalizations, but some that a lot of different people have looked at, what is the difference between the generations, or why do we sometimes have difficulty communicating? And sometimes it's not nice to read what your generation is. Like, ours doesn't actually sound that great. We're skeptical, and we need immediate, constant, specific feedback. And this is not new. For those of the residents who feel like we're always complaining about your generational differences. This is an article from when Generation X was the resident group, and we were skeptical, unimpressed, and reluctant to commit, whereas the millennials were hopeful and ambitious and loyal. So it's been, forever that people have complained about residents. So I think just keep in mind there are some differences, like in terms of electronic communication, different sort of ways to approach hierarchy, but it's nothing new, so something that we can get past. The residents want more feedback and coaching, and this is part of the model of requiring expertise. And I'm just going to play this little tiny clip by, oh, it didn't work. How do I do it? It may not work. All right, well, I'll skip it. But it's a little clip. You can look it up on YouTube by Atul Gawande. And in it, he describes, and he's written, I think, a New Yorker article on this as well, his experience with coaching. And it just kind of describes the fact that in every other field, people, in order to get better, have coaches. And so it talks about sort of his opening his eyes to how many things, even though he's experienced and attending, how many things he could do better by just having someone else watch him. And again, when we work with the residents, we should be working to be their coach and think of specific things that they can do. And this is the feedback that the residents usually get. This is probably a familiar form. This is the milestones. And as you can see, this resident is at a level 1 milestone in everything. And I think that's kind of the typical thing. And this really doesn't tell them anything. I know the milestone committee spent years putting these things together, and this really doesn't tell them anything other than that they're still an intern. And so with it's hard to see, but I changed our evaluation forms to try and force people to write something. So for each type of competency, it has specific questions, about what they know and what they can do. And this is an actual form. Everything says adequate, 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 meets expectations. So the person got around this, and I actually talked to this faculty member, and I said, do you really think that this feedback is going to help the resident? And he said, well, I thought that by not writing anything, the resident would understand that I wasn't too happy, and so then they would know that I wasn't happy with them. And I mean, that doesn't make any sense. This resident is like, oh, I'm doing great, I'm adequate, I'm totally fine. So again, people have worked to make all of these tools, so try to take an extra 5 minutes to just actually say even one thing that the resident could do better. And the other thing on the flip side for the residents, too, is people will often say, the faculty will say, well, I don't want to tell them what I really think because I don't want them to be upset and then give me a bad rating. So I think if you want, actual feedback, you also have to take that in mind and don't take things personally and accept it. And a good, easy way of giving everyday feedback is this BID model. It's briefing, intraoperative, and debriefing. And it doesn't take that much time, and I admit that I don't always do it myself, but it does really help. And so at the beginning before the case, ask the resident, what in this case do you want to learn? Just, one or two things. Have them come up with their own goals for that case and kind of agree on that. In this one, we're going to focus on, dissecting the perforator without tearing it, or whatever you come up with. And then during the case, really teach to that goal. Don't just go all over the place and tell them everything about the operation that is out there. Just focus on the goals that you came up with at the beginning. And then finally, at the end, just run through it. So it's these 4 things. So reflection. So ask them, how do you think you did? Do you think you did the objectives that we came up with? And then come up with one rule. So, one thing that you're going to remember, like never, whatever it is, or always do this. And then the reinforcement, so say this is what you did well, because they may have no idea what they did well and what they didn't do well. So tell them the things that they did well, and then also, you could work on this and correct the errors. And if it's something that will be humiliating to them, like don't do it in front of everyone else, just pull them aside and say, you did this great, but next time work on this mistake or avoid this. And this is a project that I worked on. I was in this Teaching Scholars program for the last year and a half, and I did a video coaching project. So each of the residents videotaped themselves doing a procedure. And then we each watched it separately, and we each rated the resident on a standard, it's an OSAT form, you guys probably use it as well, of operative skills. And then we met back together and we watched the video together and we kind of did a coaching session. And, the interesting thing was that the ratings were really strongly correlated. The resident and I rated themselves pretty closely on almost all the points. And they all thought that it was useful. And this was kind of a depressing thing that I took away. But I had them rank how helpful the coaching was in comparison to all of these other things. So I guess on the good side, that working in the operating room was the most useful to them, but the lectures that we give were the least, and reading only came in slightly above that. So really focus on your time with the residents in the OR, because that's where they feel like they're getting the most learning. So resident strategies for getting feedback. You should ask for it and use the tools that you provide. So we've gone through all these things. I know you guys have the phone system, I think, that you guys implemented, and we also have a texting form. But a lot of times the residents don't send it to me, So try to actually use the stuff that we have come up with, or even just open your mouth and say, hey, like, what did I do on this case? Actually, even if the attending doesn't take the time to sit down with you formally and come up with goals, you need to make your own goals for each case, Think about where you need to learn, come up with a goal, and then, ask them, teach me how to do this part of the operation. And then again, be prepared to accept both positive and negative feedback. And don't take it personally. We all want you to do better. We all want you to be great surgeons. So if we say something negative, it's meant to be helpful, and so try to just take that and grow from it. And then also realize that your attendings may not like texting you, so they may prefer to have face-to-face interactions. And then on the flip side, for the attendings, please give direct feedback. I often have the situation where attendings come to me and say, this resident is not doing this. It's like, yeah, you can tell them also, because you were there. So talk to the residents. And then when they send you these things, please fill them out and then, try to make them useful. And then again, when you're teaching, focus on specific things that they can do and things that are task-oriented. So by just saying, you're not good at operating, that's not helpful. But if you say, when you suture, hold the needle drivers like this. So something that they can actually do. Avoid public humiliation. I think that is, pretty well accepted by now, but depending on where you were trained, that may have been an integral part of your training, but these days, not so much. And then it is okay to text them. So they like to be texted. Maybe you forgot to tell them after the case, or they ran off to go take care of some other patient. You can text them hey, good job in this case, but next time, please focus on this. So those are just some tips on providing better feedback. And then the final step is reflection. So really taking a step back and thinking about what we're doing. And I recently read this book. It's written by a psychologist who's here in Denver. She works as kind of like a management consultant. And it's a really interesting book. And kind of in my years now of working with residents who are struggling, I feel like this is a thing that people who have trouble all have in common, whatever area it is they have trouble seeing what the issue is. And we all suffer from this. We all have trouble seeing ourselves as other people see us. And there's two parts to this insight. So one is internal self-awareness, or seeing yourself clearly, understanding yourself and, everything that goes into that, your values, the things that you find important, how you impact others. And then external self-awareness, which is knowing how other people see you. So accurately seeing yourself the way other people see you. And so I really encourage people to read this book. It's really interesting. And I guess I want to thank Seth, one of my residents, for, improving my self-awareness, because I guess, we've been together for a long time now. And one time he told me, he's like, "You're always so negative." And I always thought of it as this very well-developed awareness of potential complications and how to prevent them. But he just thought it was negative. And, I took it to heart, and I think I still, see complications and try to prevent them. But now, instead of just saying like, "Oh, this is going to happen," I try to explain maybe the backstory of the time the resident did that, and then, the disaster happened, or how that could happen. So I think we all have these blind spots, and especially, too, when it comes to education. We've been here, a lot of people have been here a long time. You do it a certain way, but really try to think about, whatever it is you're doing, but especially teaching the residents, what can you do better, and how you can help them and residents as well. Sometimes when residents have problems, they often say, "Well, it happened because of this," or "There's an explanation for this." But sometimes when there's a lot of different stuff, I say, like, maybe part of it is you, like this may have happened or this may have happened. But when you're having problems with a lot of different areas, try and take a step back and think, like, perhaps there's some connection there in you, and try to think about what it is. And also ask for help. Ask somebody that you trust, like, what is going on, or what can I do better? So those are my tips for today.
Thank you very much. Questions, comments? Julia.
I think one of... Good morning. I think one of the biggest barriers with teaching for residents, and I suspect attendings as well, is time constraint and really feeling rushed, whether it's in the clinic or in the OR floor or otherwise. And what are the sort of high-yield tips that you have for teaching in a time-constrained, rushed environment?
Which is nothing new, by the way. That's been going on for a couple hundred years.
Yeah, I agree. We're all busy. It's easy to let it slide. And that's why, again, like, I think you can ask people, if you remind somebody and say, "Let's come up with some goals for this," nobody's going to say, like, "No, I don't have time for that," but it does. And sometimes it's hard depending on the person. You may be intimidated by the person. It may not work for everyone. But I think, just taking like a step back, whether it's you or the attending, just try to make that space for 5 minutes, and come up with a plan, because we all want to teach you, and it's just, you're right, everyone's busy. But I think if you're feeling like you don't have that, I think just even a simple, like, asking them, "What can I do better?" That's going to prompt them to tell you. Whereas if you don't say anything and you just leave, it's never going to happen. Or even text them later, or same for the attendings. Like, if you forgot to do it, just send them a text later.
And I'm just going to make a comment, then Dr. Montero has a question or a comment. So I think reading is so key. And I bet you it's not only an issue with the trainees, but I think faculty should try to do as much reading as possible. And of course, in our world, who's got a half hour, an hour at nighttime to go through journals or electronically go through things? And this reminds me of a story. One of my best friends in residency training, who is extremely smart, a very gifted surgeon, but didn't do a ton of reading during residency. He later went on to Harvard Business School. Now he's the executive vice president for Medtronic, so he's done very well. But he was called into John Cameron's office once, and Dr. Cameron was holding up a New England Journal of Medicine, Annals of Surgery, and said, what articles are you reading? Which journals do you subscribe to? And this was in the days when there wasn't anything electronic. And John said, Dr. Cameron, Sports Illustrated, Car and Driver, and Time Magazine.
He was the guy who answered none on the survey.
So, Paul.
I just wanted to thank you for a very timely and excellent, thorough talk. The whole concept of surgical and medical education is very ambiguous and difficult. Doctor means to teach a teacher in Latin, but we're all assumed to be good teachers because we've gotten through it, but no one really teaches us how to teach. The key concepts on setting clear expectations, engaging in dialogue and feedback are all very important, particularly as today is the very first day of our brand new third-year medical students whose orientation will take place right after this. So we have a whole new generation of learners in the clinical world now, so I want to thank you for a good, timely talk.
With that, we'll end it. Thank you very much, Joyce. Great job.